Good day, my dear postgraduate students. Welcome to Glide the Slide. In this session, I had given you a case history of a 15-year-old boy with altered gait. The slide is on the screen, and I hope you had made the diagnosis. Even otherwise, description matters. Now, what am I seeing? There is a controlling normal lamellar bone over here. This is probably a bit of the periosteum, and I'm able to see a totally different picture over here. So, what can be my diagnosis? Courtesy, Nazari Wraith, and the diagnosis is osteoid osteoma. Thanks to pathology outlines for this wonderful picture. Nevertheless, before I go to the next one, I am able to see that there is a difference between this and this. Here it is more mature. I am able to see small osteocytes, and there is a laminated appearance that is visible. Here, on the contrary, it is an oven bone varying in thickness. Look at this. There is an obvious varying in thickness. They are intertwined. And there is also a varying degree of mineralization. Look at this blue areas and the pink areas. So this is what I am seeing. Now, what is this lesion? It hardly measures over 2 centimeters in diameter. Sometimes it can be as small as 1 centimeter, but then it causes an excruciating pain that the patient rushes to the orthopedician. Thanks to Wikidoc for this picture. And here, radiologically, this lesion can be very easily picked up. It looks almost like a Brody's abscess to me, well demarcated. But then, histology is ultimate over here. This was termed by Jaffe. He is supposed to be an authority on the monogram on bone tumors in the year 1935. This forms about 10% of benign bone tumors, more common in the long bones, such as the femur or the tibia. Foot and ankle are less common. As I mentioned earlier, the diameter is less than 2 centimeters. Cortical, cancellous, and subperiosteal bones are all seen in this particular picture. Steve Gallick, again thanks to the wonderful picture. Look at this. There is an nidus of tumor. It appears almost like a reactive new bone around it. It is well demarcated. This is called as a double shadow in radiology. And I'm able to see irregular bone. There are two diseases which we can mistake. One is Paget's disease of the bone. Second one can be fibrous dysplasia. In fibrous dysplasia, there is going to be the Chinese letter pattern. Here, on the contrary, there is some amount of mosaic pattern that is there, but then the intervening stroma is too much for this to be called a Paget's disease. There are the mature osteocytes in the middle. In the periphery, there can be the osteoblasts. Varying degrees of mineralization. The patient complains of intermittent, localized, severe pain. It is exacerbated at night, relieved by the anti-inflammatory drugs. The swelling is there due to vascularity. You find that the blood is difficult to be drained. It accumulates, causing severe pain. And that is due to the prostaglandins, the mediators. This obviously causes a change in gait. That is what I had given in the history as. There might be a lengthening of the bone. That is again a radiological finding. It is usually intracortical, within the cortex, not in the medulla. The differential diagnosis that we should be having as a pathologist is osteoblastoma. But osteoblastoma is usually up to 5 centimeters in diameter, whereas in this case it is hardly 1 to 2 centimeters. Etiology is unknown and it is an inflammatory or a benign bone tumor. Thanks to Semantic Scholar for this picture. Look at this very small buttonhole-like lesion right in the middle of the cortex, and it is causing the severe pain. This is exactly how it will be appearing. Orthobullets, thanks to them. So there is the intervening maze of this bony trabeculae, the O1 bone, which can be very easily differentiated from the trabecular bone or the lamellar bone. And this can be very easily scooped off and the pain is relieved. And look at the double contour that is made out in this. There is a nidus and then there is a bone. Again, there is another that is being formed. This is the reactive bone that is being formed in this case. I hope you people will be able to describe it easier now. Mosaic-like pattern, but not pages. Trabeculae of varying thickness. Osteoblast and osteocytes. Abundant fibrous tissue. And there is a variation. Sometimes there can be the intervening or the twinning in of the adjoining trabeculae. The classical Chinese letter pattern is ruled. Nidus of highly vascularized bone, intervened osteoid, remodeling by osteoblastic activity, and there will be area of lucency because of osteoclastic reabsorption. So look at these areas as though it is moth-eaten. I'm able to see some kind of a picture. And there is a new bone formation around the nidus. The evaluation can be by plain X-ray or a three-phase skeletal X-ray. This picture isn't very clear, but then this is a three-phase scintigraphy that is being done to identify the 3 dimensions of the lesion. Double density lesion I have already shown. CT scan for localizing the lesion and target shaped nidus can be made out. The histology is given over here. Apesa trabeculae of O1 bone, varying thickness, disordered vegetoid cement lines can be there. Sheets of osteoid deposition and densely sclerotic O1 bone. There are areas of sclerosis as well as rarefication. And the surrounding bone is showing thickened trabeculae of lamellar. The differential diagnosis can be 1, Brody's abscess. 2, any bone abscess due to osteomyelitis. 3, a chronic case of osteomyelitis. Ewing sarcoma. Ewing sarcoma will be presenting exactly as an osteomyelitis and many a case has been misdiagnosed. The treatment will be surgical excision, non-steroidal anti-inflammatory and radiofrequency ablation. Thanks to StatPlus and these authors for the wonderful reference. The salient points are, it is hardly associated with trauma. The nerve fibers at the end of the nidus can be causing the pain, sclerosis, and prostaglandins are found to be increased 100 to 1000 times. Wikimedia again gives a picture, beautiful. Almost like pages, but there is abundant intermittent fibrous tissue, varying degrees of thickness, osteocytes, osteoblasts, and it is a good diagnosis for us to make a common slide in the exam. And before we give a thank you, I would ask you people to glide to the next slide. The history is given over here. A 55-year-old male comes with a complaint of anosmia and episodes of epistaxis. And this is the histological picture. I would like you to make a diagnosis. Thank you.